This week on the BackTable podcast.
One of my favorite things to do, which is not a formal test as a surgeon, but it's a modified sort of get up and go. I love watching patients either getting up to go to the restroom or go somewhere, but getting across the room. It tells me everything. I've had patients where they're like, oh yeah, I'm doing great at home. I'm moving around at home. I also ask everybody if they've had any falls in the past year, because I think that's a sort of an insightful way to figure out at least a snapshot of frailty status, also, but just how they're doing in general. I've had patients where they're like, I'm great. I don't use any assistive walking devices, nothing like that. And then they get up and they're bent over and they're like holding the wall to get to the restroom. And I'm like, that is so much more telling than you telling me, oh, I don't use a cane, I don't use a walker, I'm fine to walk, I'm steady when I walk.
So welcome back to another episode of BackTable OBGYN, and it is my great pleasure to welcome my colleague, my sister, Mary Ackenbom. Mary is an associate professor of urogynecology and reconstructive pelvic surgery at University of Michigan. She is the division director there. She is also a colleague from the ACOG Clinical Practice Guideline Committee in Gynecology. And she trained at my alma mater at McGee Women's Hospital for her fellowship and then was at UPenn for residency. And then where were you for medical school? I don't even remember.
So the Ohio State University.
Oh, Are you from Ohio?
No, I'm from Indiana, but I'm I'm a
close.
Midwesterner. Been in the Midwest for a long time.
Okay, that's cool. I am super excited to have you on the show. I always like to start these episodes by asking you to tell us a little bit about your journey, like how you got here, how you developed your interests, highlight any kind of important things or not important things that you want to tell our listeners.
There's so many versions of that story, but I think the highlights are I started at Ohio State as ultimately a finance major, and I did graduate with a finance degree. My majors changed a few times, as you can imagine, when you're on the journey of undergrad and exploring. But either way, I knew that I was interested in business. But as I got into school more and thought about medical school more, it really came down to some conversations that I had with my family, my now spouse, and sort of, taking the leap and trying, right? And doing all the things you need to in order to matriculate into medical school and residency and, vice versa. But anyway, so I made that leap around, say, my junior year. Anyway, fast forward a little bit, stayed at Ohio State for med school, was just delighted to be in school. So I was, the girl, the classmate that was in the bars, for football games and whatnot, but I had the book studying. I was just excited to be at med school. It was great. Was excited to do basically, every rotation I did, super delighted with it. Thought I was going to be a neurologist, thought I was going to be an anesthesiologist, hit OBGYN, and I was done. I was sold. Fast forward to residency. Philly is amazing. It's such an amazing city. It was an amazing time as a resident. And then I did my Urogyn rotation, and it was then that I knew. And I didn't know much about Urogyn before. I had a little bit of exposure in medical school, but didn't really have an idea of the depth and the breadth of the field. And then I had the opportunity to, as a rotating resident, and fell in love with the work that I'm doing now. Fast forward to Pitt. I was there for a fellowship. I honestly thought Pittsburgh was going to be a pit stop. I was super excited to match as a fellow, but didn't know that I'd want to live or be living there for as long as I did. I stayed there for 11 years. Pittsburgh is such a charming place, and I really enjoyed my time there, both personally and professionally. And now I'm here in Ann Arbor, and it is a bit colder up here. I thought it would be sort of similar and spending some time in Erie, but it's a little bit colder, but the people are wonderful. The community is wonderful, and everything's been great. And really, again, just delighted to be practicing urogynecology. I mentioned along the way in medical school, I was sort of dabbling and interested in many different things. Geriatrics stood out to me. Even then, of course, surgery, and as a urogynecologist, urology. I will say this work, this interest that I have specifically in, taking care of the oldest old, outcomes for older adults, it really, from a research standpoint, launched when, as a fellow, we started seeing patients who were coming back in, as they typically do for their follow-ups and recoveries, and started really just having conversations with one of my attendings in particular, but talking about some people who returned and said, yes, I feel great from a bladder standpoint. I feel great from a postoperative standpoint, meaning no pain, no nausea, meeting all my milestones, but I'm a little foggy. Or a family member is saying, oh, mom's just not the same anymore as she was before the surgery. And that conversation that I had with an attending sort of launched into what's now my research career, my research interest and focus, which is on perioperative neurocognitive disorders. But overall, I'm interested in how do we both understand and optimize outcomes for older adults, especially as urogynecologists. We are in the business of taking care of people and improving quality of life, right? Like, it's not cancer, it's not pain. It's absolutely, bothersome and disruptive to life, but it's different, right? There's a different set of considerations that need to be taken into account. And because we are focused on quality of life, I think it's really important for all of us to be looking at all elements of quality of life and not exchanging one element for another.
Let me back up for a second and just ask, so you've been with your husband since medical school?
We met my freshman year of undergrad. Yeah. So he's been through it. He's seen it all.
Yeah, that's pretty amazing. And also just so important when you're making all these choices. Is he in medicine
He's
or not in
not.
medicine?
He's in finance.
Okay.
He's in finance,
Oh, okay.
which I also think is a nice perspective to have at times, just somebody who's not in the thick of it, but has seen, has been through the journey too.
Yeah, you can't make these moves without his support. Absolutely not, because you've had a couple moves in there along the way. And we're talking about the span of, as our listeners know, 20 years or whatever. So it really, you need to get buy-in. It's a long time. The other thing that I wanted to share is something I learned about you, which was your love for, was puzzle competitions.
I like to speed puzzle. It is so relaxing, and it is a way to, one, do something that you just focus on the puzzle in itself. And, I am not a speed puzzler that does 1,000-piece puzzles. I'm not that fast yet. One day. But I love a 300-piece, a 500-piece. You can take an hour, hour and a half, maybe a couple hours if it's right? And you just, you have a strategy. You're trying to get faster and faster. You have sort of benchmarks for yourself. I think it's lovely. It's so fun. If you haven't done it, please do it. I think it's just so great.
I want to bring this up only because I think it's a piece of the puzzle, because, what we do in terms of reconstructive surgery is putting it back to the puzzle.
Yes.
And it's you have to have vision.
Yes.
And you have to remember and know the tissue planes, but also just make sure it looks good and feels good and all of that. I can see it is putting a puzzle back together. The residents laugh because I love to bring the hymen back together, and
Same.
Because you can tell where it tore, and I'll just say, I'll bring it together with Alice's, and I'm like, look, it's Pangea. And people were like, Pangea? I was like, all the continents were together and they fell apart, and now I'm putting Pangea back together. And they're like, oh, how funny. Because you can see where it all tore.
Broke.
But anyway, we are literally putting Humpty Dumpty back together.
That's right. All the pieces back together again. Mm-hmm.
But anyway, I digress. So I think that's super interesting about your research focus because, and this is something I always tell people, we should be doing research and things that spark joy, are interesting, and it often is based on a clinical observation. And then when you explore it more, you realize there's not that much in that particular area and is a gap in knowledge, and you've forged your career in that. So I think it's super interesting, and I've followed your career with a lot of interest. First of all, you're one of the only Black women in the field, but also one of the only ones researching this area. And you had obtained, I think, some NIH funding early on in your career as well, right? To explore this area. And then you have had pretty good success, getting grants along the way. And I know it's a tough environment right now, but I do want to let our listeners know that this is something you have really dedicated. It's not a casual interest for you. It's definitely something that you've been locked in for a long time. So I just want to set the stage and just ask, When we talk about gynecologic or urogynecologic surgery in the older population, which is most of our patients, I mean, occasionally I operate in 40 to 50-year-olds, but really mostly over 50 and a lot of patients over 60. What physiologic changes matter the most perioperatively, and how do they differ from chronological age?
You say chronological age, and it makes me think the dichotomy that comes to mind right away is age versus frailty, right? And so with physiologic aging, I think some of that does go hand in hand with the chronological, but I think the frailty piece is where it differs. I often, even today, I will sort of mention to a fellow or my clinical team, like, oh, this patient is 70 years old, but she's a young 70. Or it's like, oh, this patient is 88, but she's a young 88, right? Like, is it old or is it young? What is it? And what does that mean? Well, it really doesn't mean their age. It means their frail status, because I think that frailty is much more closely tied to poor outcomes than age in itself. Of course, as we're thinking about aging in general, we're thinking about, how is the heart functioning? How are the kidneys functioning? We know 38% of older adults have chronic kidney disease. So we have to be thinking about the things that generally come with age. But I think comorbid status and frailty is more relevant than age in itself, because age doesn't always tell the full picture.
So can you define what frailty means?
Sure. So the way I define frailty is it's a state of vulnerability that one has. We tend to see more of that vulnerability, sometimes with increases in age, but also it can be with more comorbidities, as you can imagine. More cancer patients tend to be more frail. Those who are underweight, sarcopenia, those are adults that can tend to be more frail. But really, I think of it generally and broadly as a state of physiologic vulnerability.
Okay. And then what age or clinical inflection point do you personally change your perioperative playbook?
Ooh. That's a good question. I don't know that there truly is an age per se. Again, because I'm thinking more about frailty. But in general, I will say 60 for me has been a cutoff that I have used in a lot of my prospective studies. But, depending on who you ask, especially some of like my geriatrician colleagues who are, clinicians and researchers, they would say 60 is not old at all. That's very, very young. But I do think 60 is sort of a nice threshold for when I do need to start thinking more broadly about, hey, how old or how frail is this person? So 60 is when I start thinking about it. But again, that vulnerability, that frailty or pre-frail status that you see is very wide-ranging, especially with our patients in urogynecology.
So what procedures are you most, generate the most perioperative complexity? And it doesn't have to be just urogyne. It could be any kind of gynecology procedure. I mean, you alluded to oncology. I'm assuming like ovarian cancer.
Yeah, definitely with the cancer states. Those are patients who already have a heightened level of baseline inflammation. I think when you have that inflammation that's already circulating in your body, that has an impact on how the different organ systems function. And then you take on top of the inflammation, what is the treatment for cancer too, right? And so that in itself can contribute to weakness and vulnerability and whatnot. So I do think gyn-onc is its own set of considerations given the disease states that patients bring to the table. You mentioned specific surgeries. That is a really interesting question. I think often the teaching is that, a vaginal approach is the, way to go from a minimally invasive standpoint, right? It's the most minimally invasive. However, I feel like over the years, we have studied, we're taking our oldest old and often doing some obliterative vaginal surgeries. And this is where we're seeing the hematomas, right? Not that hematomas are super common, but complication-wise, it does make you think a little bit more about, is the colpocliosis, is the obliterative surgery the absolute best way to go based on age alone? And I feel like sometimes that rhetoric gets pushed, and that's not always the scenario or the best case. we started looking at who are these older patients, like in their 80s, getting sacrocolpopexies. I've seen some people where like, I would not even dare offer a sacrocolpopexy to someone over the age of 80. But again, 80 is the new 60, 60 is the new 40. So people are getting older. We're going to see this more and more as the decades go on. And so I think from a surgery standpoint and thinking about the complexities that these surgical approaches bring, I think that we have to be charged as surgeons to really think about all of these are minimally invasive approaches. What is the most ideal approach for this patient? Because sometimes denuding a vagina in its entirety may not be as efficient and may not provide for the most ideal recovery state for a patient who could get a sacrocolpopexy that might be more efficient. In fact, even though it is a little bit more invasive because you're going intraperitoneal. Food for thought.
Oh, interesting. It's actually very interesting that what you're describing, because that is not the general gist of the field. But I think what I'm hearing in your messaging is individualizing the treatment and care. And this is how you go about shared decision making, which is, like we're saying, it's all quality of life conditioning, the conditions that we're treating. So what works best for the patient. So tell me a little bit more about counseling the patients about operative risk and what strategies help align your surgery with the patient priorities.
I think that from an operative risk standpoint, and there's a couple of different buckets with this. I think there's the standard surgical risks, the consenting process that many of us are familiar with and comfortable with as we think about surgery in itself, where we're talking about bleeding risk, infection risk of prolapse recurrence or incontinence recurrence, whatever the indication is for the surgery, DVT, stroke, heart attack, anesthesia complications, urinary retention, those things that we talk about often. I think the piece that comes in where I sort of fine tune it a little bit more and have changed the way that I counsel my patients is for my oldest old, where I am talking a little bit more with intention about the risk of cognitive decline after surgery and perioperative neurocognitive disorders. I do explicitly bring it up. I do think that for some patients, it's already on their mind. For others, they're not even aware of it. They're not thinking about it. But again, being that we are surgeons in the business of improving quality of life, this is very much something that can change that quality of life for them, especially if it's something that lingers or if it's something that is existent and then can cause a sequelae of other issues like falls, medication errors, etc. So I do explicitly counsel patients about those risks because it allows for us to talk about it. And then it's an open conversation. I can get a sense of their concerns. I can get a sense of what kind of support they have at home because ultimately we have a discussion about, what things to look out for and what to do.
What's the threshold for oldest old? Is it patients over 80 or is there like an official definition
There's
of
no
that?
definite. That's mine. For me, it's over 80. When I'm talking about oldest old is over 80. But anybody who is over 60, it is part of my standard template to talk about cognitive decline after surgery. I usually describe it as brain fog because I feel like everybody can relate to that, but there's no definition for that. But that's a sort of a way to introduce it into the conversation. And then from there, we're talking about it a little bit more. But everybody over 60, I talk about it.
So what causes those cognitive postoperative issues? Is it the exposure to general anesthesia and the length of surgery? Because I know I've had a couple patients who have explicitly already done their research, like say they have already cognitive decline or a diagnosis of dementia. And then usually either the patient or the spouse comes in and says, I want to avoid it. I want to do it under spinal, et cetera, et cetera. So I think it's getting out there, but what is your take on the reasonings that this happens or the etiology?
The etiology truly is multifactorial. And I know that's like, what kind of answer is that? But truly, it really, really is. So, I think in the 90s, there was the people who were doing this research, it was largely anesthesiologists and geriatricians, there weren't lots of surgeons that were doing this. But the thought was, oh, this is anesthesia driven. The more general anesthesia, the more inhalational anesthetic patients are getting, the greater the risk. And that's what we're seeing more of, right? The bigger the surgery, these are heart surgeries, people are on bypass, these are neurosurgeries. Of course, you're working on the brain, right? The thought was that those were the people who are impacted. But as the science has progressed, we have found that this is happening in settings where it's not surgeries necessarily on the brain or on the heart. These are, non-cardiac, elective, but major surgeries. There's even some data to say that it's happening with minor surgeries too. As they've looked at, is it anesthesia, right? Can I do regional anesthesia to avoid this from happening, regional versus general? They've actually done some pretty good meta-analyses, and they have found, especially with the improvements in anesthesia, particularly with ERAS, it's not really one or the other that is protective per se. So at this point now, especially in the advent of ERAS, I don't say, oh, we should talk to an anesthesiologist, do an anesthesia consult to get you regional to protect your brain. I don't say that because the ERAS protocols that have been sort of tweaked and used, they're really good now. They're using more intravenous meds as opposed to inhalational meds. They're really thoughtful about which medications they're giving, and outcomes look pretty similar. So I'm not out there strongly advocating for, oh, you need a spinal for brain protection. But there may be other reasons, right? If you have heart disease or something like that, something else going on with your body that you're going to better benefit from a regional anesthetic, then yes, we're talking about it more.
That's super fascinating what you said about ERAS, and we're talking about enhanced recovery after surgery, because both of our careers have spanned the birth, genesis of ERAS, and it has been transformational. Truly, I think a lot of our listeners are on the younger side. Please just know how much better life is with ERAS. My residency and fellowship, so many pulmonary complications from fluid overload. I think the cognitive sequelae were a lot more, actually, before. We had everyone inpatient. We were overloading them with fluid all the time. People didn't realize, we just didn't understand catecholamine release, how our bodies react. It was just we were doing these 3-to-1 resuscitation formulas with crystalloid and colloid, calculations. And it was just it was not taking into account the physiologic processes of the stress of surgery, essentially, and how we get activation of the renin-angiotensin system and aldosterone and retained fluid and all the things that, we were just at the infancy. So now with multimodal pain regimens, with early ambulation, mobilization, feeding, all of that stuff has gotten so much better. And it is a sea change. And then actually outpatient surgery.
And going home. Explicitly going home. And some people are like, oh, that's not necessarily
it's safer.
A good thing.
Safer to stay in-house.
Safer.
No.
Yeah.
No, it is not safer to stay in-house.
Go
People
home.
have delirium. They're chained to the bed with their Foley. You can't sleep. You're woken up all night. It's terrible. So honestly, it's not like I'm trying to talk people out of the hospital because I don't want to round. I'm really talking them out of the hospital because I really truly believe in my heart of hearts it's a better place for the patients to recover, to be in your own surroundings, in your bed with your loved ones, helping to take care of you, eating regular food, drinking regular drink, not being hooked up to an IV, walking around. The mental, even when I go to a hotel if I'm gone for more than a week, I'd rather be home. It's not fun for me to be outside of my house. I guess I just like being home. But I think most people are like that. So I think you bring up a really, really good point about that. So how do you handle borderline or gray zone cases where surgery is reasonable, but the benefit may be modest? Is this where you're just kind of have the patient's goals guide you?
I do. It really is a discussion. Every single one of my patients who I meet, it was new, regardless of age. The last question I ask them before moving on to exam and whatnot is my magic wand question, which is, if I had a magic wand and I could fix anything related to your pelvis, symptom-wise, what is the first symptom? Because I really find that people will come in sort of telling me all the things that they are aware of, or another, clinician has told them that they have, whatever the case may be. But then when I ask them that magic wand question, it sort of, reveals like, what do they want? Like, what is the goal? What do they want fixed? And it really allows me to sort of like tailor the conversation to, let's talk about what these interventions can do to achieve this goal. Is this a reality or is this not? Right? Like, so some people will come to meet me and they're like, I need you to do, prolapse on my, what ends up being like a stage 1, maybe if we're really bearing down hard and squatting and doing all the things in the office, barely a stage 2 prolapse. And they're like, yeah, I need you to do this because I don't want to leak anymore. I'm like, okay, we need to have a conversation, right? Your prolapse is not necessarily contributing to your leaking, and here's why. So I do like to upfront early on ask what the goals are, because that is going to help us develop the roadmap for what the options are and how we move forward, and really talk about, is surgery the right call? Or do the benefits outweigh the risks that sort of come with it, in thinking about you as a person and what you bring to the table from a risk standpoint?
I really like that. In my old practice, we did have them write down their top 3 goals, but it's such a good point about honing in, because when we're talking about urinary incontinence, it's like, is the urge more bothersome? Because that's a different pathway. Like, should we start the meds, go down to Botox? Should we talk about the sling? What should we be doing? People have a misconception when you take care of the prolapse, the urge is going to go away. Well, sometimes it does, but it's like, this is just for the prolapse, and so that is, something that you really have to frame, I think, when we're talking to the patients. And I always tell people, I'm like, you know what? I want to under-promise and over-deliver, because you got to frame this. And then also the other thing that we have to frame, in addition to the risk of surgery, like you talked about the risk of cognitive sequelae, for instance, but also just the fact that sometimes our surgeries don't last forever. I mean, for reconstructive surgery, it doesn't last forever. For extirpative surgery, for hysterectomy, yes, that will take care of your bleeding forever. But there's now sequelae that we know from performing hysterectomy, which is actually something that was a big theme of our last meeting. It was very interesting about the cardiovascular sequelae and that kind of stuff, which, I'm still doing a lot of hysterectomies, don't get me wrong.
Same. But the hysteropexy, I think, is going to be, I think there's going to be a surge in we'll see what the numbers show over the next few years. But I feel like I'm seeing more and more patients come in and they're like, can you fix this and leave my uterus in? So, we'll see.
Yeah, I don't know. We already knew that premenopausal hysterectomy decreased the age of menopause by 2 years, but then all the other things associated with it, it's like, these are associations. We don't know causality. And I will say, in the Midwest, it's not the culture to keep your uterus.
No.
Per se, but
Maybe you're like, oh, I don't need it, right? So you can just get it on out of there. But I am seeing more and more people, at least, asking the question of, oh, do you have to do this? I'm like, well, actually, it's kind of, prolapse surgery is kind of like an a la carte menu. We can kind of pick and choose the different parts that we want to do. You don't have to commit to, one thing. And anyway, so yeah.
And then a question for you, when you talk about the comorbidities and the frailty, when do you bring in clearance? I'm doing that because I know certain practices are very big on getting PCP clearance. I would say Cleveland Clinic, like, we use our judgment, I guess, and we send it to pre-anesthesia clinic. But like you said, it's not like hard and fast criteria. But it seems to be very regional. I know for myself, I usually bring in like very specific questions I'll have for consultants, like, okay, patient has a history of MRSA in the past. Like, do we decontaminate? What is the perioperative? Atrial fibrillation is so common. I manage that myself, actually. But, for other kind of more complex conditions, like how the anticoagulation plan, things like that. What is your thought? Has that ever resulted in better outcomes?
I feel like this is a practice pattern of mine that continues to evolve. I have found that, and I agree with you regionally, like whether you get it or not, sort of depends on the practice pattern of the practice, or, because there are some things where a pre-op visit, let's say where I'm at currently, it's sort of built in where the anesthesia team is doing this. And so they're also taking care of making sure to educate the patient about, okay, this is immediately what you need to make sure you're not taking medication-wise. They're going through their medication. So there's some things that check boxes from a logistics and efficiency standpoint with doing a pre-op visit.
Yeah, we do that too. Like we send to the pre-anesthesia clinic and they order the labs.
Yeah.
The only lab that I'll ever draw actually is a hemoglobin A1C, because I will change whether or not I do that. And everybody has a different cutoff. But I mean, the literature is very clear now that the higher it is, the worse it is perioperatively for outcomes. So, ideally it's as low as it can go. But I mean, people's threshold, sometimes it's 9, sometimes it's 8.
Ooh.
It really depends.
Yeah. I'm not at 9. Well, that's not true. It's not that I haven't done it, but it is I won't do mesh with a 9, but it is a conversation for sure that we are having, because you're right, outcomes are much different the higher it is. I will say though, so especially for my older patients that have comorbidities, or I suspect they have more comorbidities and they're not listed or they're not being disclosed, I do like engaging the PCP for a, perioperative evaluation. And here's why, especially if it's one where the PCP knows the patient, they've known them for years. That means they have a good sense of their history. What are their ongoing issues? What is their status? And they're really able to give me a nice perspective of, yes, these are the things that have gone on with Mrs. X. And, these are the things I would want you to be aware of, but she is good for surgery or not good for, whatever their impression is. But I have found that sometimes they can give me insights that I'm not able to always pick up. EMR has gotten great. Now that we got care everywhere, I'm able to see notes from all sorts of different places, but I still, every once in a while, I'd probably say even once every other month at this point, we'll have a patient who's like, yeah, I'm healthy, I'm great, things are good, and I'm going through the things. And then if I chart dig a little bit harder, or if I ask for a PCP assessment, comes back, they've had a cardiac cath, comes back some sort of information that would sort of inform like, oh, that might make a difference with their outcomes. That's definitely going to change their risk level. So I do think engaging the PCP can be really good. It depends on what the patient is bringing to the table and what we're planning to do, especially with like a major surgery. Then I'd be thinking about that more, especially if they're more frail.
Yeah, I'm a minimalist. I have like a totally opposite kind of practice because you and I have gone to the meetings for many, many years. We go to a lot of meetings. So anyway, it's like all these data came out about like the utility of perioperative labs, like pre-op labs, post-op labs, and they're just basically useless. I mean, if I have a lot of comorbidities, like usually they have some sort of thing in the computer over the last couple of months or something. So I get a gist of what's happening.
Yeah. If it's there in the system, it's great. And then the other token of this is, right, like, yes, it's great to engage a PCP, but if the patient doesn't have one, it doesn't, right, then it's not as helpful, right, for them to go and see somebody who doesn't know them. They're going to say the same thing they said to me, and then they're just going to write it down. It's not efficient. It really is the person who is like, oh yeah, Dr. Jones has taken care of me for 10 years and knows all of this about me. Those are the ones that I think are a little bit more helpful.
Yeah, it's funny because like I also trained in an era where we were chasing hemoglobins and like obsessing what it meant that it was going up and down a little bit. And these hemoglobins, they go up and down. That's the way it is. And it means nothing. So I just follow them clinically now. Don't get post-op labs. Like,
well, no, because they're going home. So we should not be getting one.
Well, that's right. You can tell by their blood pressure. I mean, we already know that acute blood loss, you have to go by their vital signs. Their vital signs are vital.
Vitals are vital.
So,
vitals are vital.
Your urine output, blood pressure, heart rate, those are going to give you like your major info. And usually they declare themselves. If you're worried, you're worried. But anyway, the other thing that I wanted to talk to you about, because this is interesting about the patients, is, the whole concept of prehabilitation has taken hold in a lot of surgery programs. It's not my sense that it's taken hold of urogynecology per se, but I do follow it on, it's an ACS, American College of Surgeons initiative. There's been a lot of data coming out about it. It's, for me personally, what I struggle with is that What are the resources? How do you refer them? Are we supposed to be doing the grip strength thing and like figure this stuff out? Because it's like a kind of like a, I don't know, can you describe for our listeners what the concept of prehabilitation is and what it entails?
Sure. I think the way to best think of prehab is essentially is getting a person sort of tuned up and ready, right?
Optimized.
Yeah, it's like getting them
optimized.
ready for the stress that is surgery, surgery being the controlled trauma that it is. And so a lot of these prehabs are really focused on like physical reserve. There are a few studies out there starting to look at like cognitive prehab, right? Thinking about, is there anything we can do from a cognition standpoint? So yeah, this is, getting up your stamina, right? From like a physicality standpoint, if you're able to do that, the thought is that you'll be able to withstand surgery better. And also after surgery, you'll be able to sort of reinvigorate or restart closer to that new baseline that you created in your recovery too. We know that more activity tends to be better in the postoperative setting. So this is just setting people up so that way they continue to do better on the second half, on the post-recovery end.
Yeah, I think the obvious ones are obvious, right? Like stop smoking, get their diabetes under control, weight loss, if they are sarcopenic or under or something, check an
protein shakes,
albumin.
right? Protein shakes.
Yeah, like getting them, get their albumin up, nutrition consult, etc. I think that, I think it's the rectal prolapse patients. There's a segment of like the eating disorder patients. So making sure that they are optimized for surgery is super important so they don't fail. Sometimes we see this in the postpartum population where their tissue is just terrible and like it's a whole question mark. Like they're breastfeeding, it looks really bad. Like when is the optimum time to take them back after an injury, that kind of thing? Is it like 6 weeks? Is it 3 months? Should we do it right away? There's a lot of, we don't know.
And there's been shifts in that over the years too.
I know. Because I think before it was like, wait 3 months. And then patients are so miserable for 3 months. It takes a hard heart to not, like let me take care of something. Anyway, do you think that minimally invasive surgery has changed perioperative risk in this population? Because we used to do a lot of open surgery.
We did. And I do. I think minimally invasive surgery has made it so that people, their trajectories of recovery are faster now, which is great. I think it's made it so that people can go home. I'm not sure that if we were doing open surgeries, we'd still be good with people, sending people out with a midline vertical on day 0. I don't think we'd be, I don't think we'd all feel as comfortable with that. So I do think the minimally invasive approach has been helpful in sort of moving the needle and allowing people to recover faster, or rather just recover. They're starting at a place that is much closer to being recovered than they would be having an XLAP of some kind.
What complications increase most notably with age after gynecologic surgery? You said the cognitive stuff. Would you say that?
I think urinary tract infection is super high, right? But also, I really think that we all need to be talking more about cognitive decline after surgery. I do. I think that delirium is underdiagnosed. We don't talk about it enough. It's under-recognized. People don't know what it looks like. Often people, when they think of delirium, they think of hyperactive delirium, which is where people are hallucinating. They're agitated. They're seeing things. It's the person who's ripping Foleys or IVs out, right? That's what you classically think of. It's what you're classically taught when you're taught about delirium. But really, there's a large proportion of people who experience hypoactive delirium. And that's then with people who are somnolent. They're sleeping, psychomotor retardation, slurred speech, slowed speech, right? And so people are like, oh, you hear this often. Oh, they just need to sleep it off. Anesthesia is still wearing off in their system. Just give them some time. And sometimes it is that they just need that element of time. But it's also possible that they are delirious in that moment. And that has implications in itself, especially, delirium, it waxes and wanes. It comes and goes. And so when we don't recognize it or don't acknowledge it for what it is, it has the potential to lead to sequelae that I think can be prevented. So I do think delirium is one that we need to be talking about and thinking about for urogyn surgery, but really for surgery for all older adults. We need to be talking about it more.
I think it was your paper. Didn't you do a prospective study that was presented at OGS about the incidence and prevalence of postoperative cognitive issues. And it was extremely high. Like, I can't remember. It was like 60% or 80%. It was a really high.
So with postoperative cognitive dysfunction, or what we would call postoperative neurocognitive disorder now, the nomenclature has changed in recent years, but that is a more subtle type of cognitive decline that happens after surgery. It is related to the timing of surgery, but it's an issue where people are now having a new problem with memory and information processing and concentration. These are all things that you need to be able to do to take care of yourself. And we found in the first cohort of women that we studied this in, all over 60 years old, a third of them had met criteria, which was at least one standard deviations decline on 2 or more tests, or a big 2 standard deviations decline on 1 or more tests in this cognitive battery. Take home is a third of them had substantial decline at 2 weeks after surgery. This is the time point where family members have gone home, people are driving again, people are largely taking care of themselves again. So it was quite striking to me, and I think hopefully striking to others who were seeing this. So we did this again, but we looked over the course of more endpoints, essentially. And so we still found in the second cohort that it was about 35% at 2 weeks. And then at 3 months, we found that 25% were still meeting criteria, which to me, 3 months, we're supposed to, that point, no more restrictions, you're good to go, lead your life, be happy, call us if there's any other issues, but most of us are signed off at that point. And we're still seeing issues with cognition. We're learning more with this work that I'm doing now, what does this mean, right? This is formal neurocognitive tests. Everybody's not doing neurocognitive testing batteries in their day-to-day life, but we have paired this with other testing where we're having them do medication management tasks, and bill paying tasks, check writing tasks, shopping tasks. We're trying to see how this really influences functionality, and we're evaluating that. But it really is striking, and I think at least the first thing that we need to be doing is talking about it more. This can happen. This does exist. Yes, what we have seen in the literature that's published largely, it should resolve for most people by a year. But in the time frame that you're recovering, you have to be on the lookout so you don't hurt yourself. I don't want you to fall. I don't want you to take too many meds. I don't want the sequelae that can come up from having these issues as it relates to your brain being, quote, a little bit fuzzy, but really having these neurocognitive issues.
So can I ask you, you know how patients will often come to the office and say, when should I have surgery? I don't want to get too old or age out of surgery. And I never really believed in that until I met this one patient. And it was just very recently, within the last year. And she was 95 and she'd had this prolapse forever, for 20 years. And we couldn't get her optimized for the OR. Her platelets were low. She kept on getting UTIs. She couldn't void because her prolapse were out 15 centimeters. I mean, this prolapse looked like a naked mole rat. It was coming out so much, and she was so miserable, and her son was tortured. I have 2 boys, so it hit home. I was you could tell her son was I don't want to be dealing with this at all. My mom is miserable. I need to get her to the OR. But should I be saying to my patients, let's try and do this before you're 60? Do you know what I mean? Because it's hard. Because I tell people, well, this is just like the orthopedic surgeons wouldn't operate just on x-ray findings of arthritis. You need to tell me when you are having these bothersome symptoms that impact your quality of life. It's asymptomatic. I can't improve on that. But when you get intrusive thoughts, that's the time when, and it's impeding you from doing the things that you want to do. But at the decision point of age alone, or, those kind of things, can we avoid this? When I go for my plastic surgery, when I get my facelift and my Mani makeover, should I do it before I'm 60? What's the story?
This is such a good question. And I think about it often. In my mind, I call it the surgery window, because my patients ask me about this often. They're like, should I do this now or do I wait? And I've seen it where it's, my 30 and 40-year-old patients. And I feel like I kind of know generally how that conversation goes, but it starts to get a little bit more tricky when we're talking about patients who are older and have a couple more comorbidities, right? And so you're tinkering with, okay, if we wait, that can be okay, but we don't want to miss our window, right? We don't want to miss the opportunity, because in a year from now, unfortunate circumstances may take place, right? We may have issues keeping your platelets up. You may have had a stroke. You may have had, a cath in now or a stent in now. So we have to wait. Circumstances could be in place that encourage us to avoid doing surgery. And I don't have a good answer for that right now. I think about it often, though. And it is a conversation I have with each of my patients, and I try to really individualize it. And we're talking about their degree of burden and bother. And that sort of, I think, helps us to figure out where that needle lands of when do we need to go. Some patients say, I'm glad to be aware of what the status is of my prolapse and my pelvic floor. And now I know I'm going to come back once a year to check in. And I reinforce great, I can check in and objectively measure, but I'm also going to be checking in subjectively. Are you avoiding the things you love? Are you not playing pickleball? Are you not going out? Are you not engaging in, intimacy with your partner? Whatever it may be, I'm going to be checking in on those things because that may sort of tell us where the needle is landing. But I think the window is different for everybody. And I would still say it's not age-based. At least I don't think so. I think we're just aging so fast, right? There's going to be so many more 90 and 100-year-old people here over the next few decades. And so you don't want to do it too soon without indication or reason, but it is something to really be thinking about for the patients.
I agree with you. I mean, there was do you remember a couple years ago, there was a calculator that was a real age calculator,
Yes.
and you put in all these characteristics,
Wow.
and then it was and I punched it in and I was like, haha, I'm younger than my real age is younger than my stated age. But what you're getting at is kind of like that. I mean, you see patients who are in great shape and you can't believe that they're 70 or 80 or whatever. And then you see a 60-year-old and you're like, oh my gosh, life has been harsh.
Indeed.
It's been a tough health ride for you, So yeah, I agree with you. I think we have to individualize care. It's hard to make these generalizations, but there are some themes that we have touched upon and to keep in mind. What do you do to screen for patients at risk for the cognitive issues,
So some people ask me, are you doing a cognitive screener on everybody in the office? I am not yet. If somebody gives me the sign that I'm oh, I should do this, then I will. And then in those cases, I may do a simple Mini-Cog, which is simple. You just give 3 words that somebody needs to, restate for you. So you know that they have basically registered them in their memory. That's sort of an immediate memory task. Then have them do a clock drawing for you and then recall the words. That's more of a delayed recall. So sometimes I'll do a Mini-Cog. But if I'm really concerned, I'll bring it up in conversation and then we'll discuss it. And then if we're still concerned together, right, there's subjective concerns, I have objective concerns, then that's something I would flip, let's engage your primary care doctor because they're the ones that are, often doing this and can give more insights and do more robust testing if need be. One of my favorite things to do, which is not a formal test as a surgeon, but it's a modified sort of get up and go. I love watching patients get up and go to the restroom. If either getting up to go to the restroom or go somewhere, but getting across the room, it tells me everything. I've had patients where they're like, oh yeah, I'm doing great at home. I'm moving around at home. I also ask everybody if they've had any falls in the past year, because I think that's a sort of an insightful way to figure out at least a snapshot of frailty status, also, but just how they're doing in general. But I've had patients where they're like, I'm great. I don't use any assistive walking devices, nothing like that. And then they get up and they're bent over and they're holding the walls to get to the restroom. And I'm like, that is so much more telling than you telling me, oh, I don't use a cane. I don't use a walker. I'm fine to walk. I'm steady when I walk. I don't have falls. But if you're grabbing everything because you are unsteady objectively, that tells me what I need to know.
So for those patients that you're concerned about their frailty, do you preferentially do more vaginal surgery in those patients? And say, I want to do a shorter surgery, minimize your time under anesthesia?
I would say I probably end up doing a vaginal approach. I don't say it's always completely off the table, but I end up probably doing more vaginal surgery. Because again, you want to get in and you want to get out, right? The thought is that the surgery in itself, as sort of a controlled trauma, releases all these inflammatory mediators. What is it going to do to the state of somebody who's probably already inflamed at baseline, which we know impacts the brain too? Yeah, the goal is to get in and get out. I wouldn't say it's a hard and fast rule that it's oh, yes, it always should be a vaginal approach, but more often than not, it usually is. These are people you want to go fast, move quickly.
Yeah, I agree with what you're saying, but I think this is a rapidly changing in terms of our insights. So I want to thank you so much for coming on and letting us know what you found so far. And I know you're going to continue to elucidate these questions as time goes on, because really it's sort of an underexplored area. And I think across surgery, the house of surgery,
Yes.
like general surgery and other
Everybody. Yeah.
other disciplines, people are paying more attention to this. And I would love to hear a lot down the line, like best practices of how to screen, treat, counsel these patients, because we do elective surgery in gynecology for the most part in this patient population. So not the cancer surgeries as much, but those are indicated. But, I think these are really important issues. And like I said, I think ERAS has really been
A game changer.
really, really helpful.
Truly.
Game changer.
Truly.
Yes.
And then there is a good guideline out from, it's ACS, American College of Surgeons, and AGS, which is American Geriatric Society, on best practices for, perioperative care of the older adult. And it's thorough. It's really, really good. Hits on multiple different sort of elements and aspects that should be thought of. And I think that, one of the really great pearls that comes in there is really, expectation setting for the patients and making sure they have support, I think is huge. All of my older adult patients, in fact, everybody, but especially the older adult patients, I strongly recommend that there is someone physically with them for the first 3 days after surgery, because of the risk of delirium, but also just it's that early part of recovery. If anything comes up and you have a support person there, it's likely that they may be able to intervene or at least recognize it. And so when the team is calling the next day to sort of check in, they may be able to provide insights that are helpful, since we don't have our own eyes on them. So yeah, I think that support system pearl is a really important one and a good one. And then again, just a shout out for those guidelines. I think they're really great. If you haven't seen them, take a look at them. They're really good.
Yeah, I think that the other thing to keep in mind with all of this is another reason to go home. And, and it's good to have your support, of course, but also just the muscle loss is tremendous with the older population. I don't remember what it was estimated per day, but I remember seeing a statistic, and it's quite a bit. Like if the patient is in-house for a couple of days, they can really lose a lot of functional status very quickly. It's like a precipitous decline. It's not like, you and I don't work out for 2 weeks and then, whatever. It's a lot. So, all of these things go into recovery. And I think that's another area in our field that is starting to get a lot more attention is postoperative recovery, turn to baseline. You're really focusing in on a certain patient population, the older patient population, and cognition. But I think just physical recovery also, people are obsessed with, when can I go back to work? When can I start working out again? It looks like it's about a week for slings and 2 weeks for prolapse surgeries, 2 to 3 weeks. It's like, I know for prolapse, I saw that at our last meeting, it was like 50% say they're totally recovered by 2 weeks, 75% at 3 weeks, 80% at 4 weeks, and then like at 6 weeks, it's like 92% or 94%. So it really is a tincture of time, like you're talking about, but that's using physical recovery. I think what you're describing about cognitive recovery and taking up to a year, that is pretty.
That's the thing. It's a whole different, it's an element of recovery generally, but it's also something we're not measuring, right? Like it's hard to know what this is if it's not included in the measures that we're looking at when we're studying it from a research standpoint. So it's something that just needs to be thought about and talked about more as we're figuring this out. My hope and goal is that one day we'll be able to, you talked about like a chronological age, and the other thing I'm thinking about is brain age. And there are some measures that we can sort of use with biomarkers, brain imaging, plasma serum, things like that, that can sort of give us an idea about brain age. And I think it'd be incredible if we can, right now, we get EKGs to look at heart function, and we look at serum creatinines for kidney function. I think it'd be great if we had some sort of blood-based biomarker to tell us about brain age, and that could give us insight to one's brain risk as it relates to surgery. So hopefully we'll have something like that in the future. There's just more work that needs to be done. But for now, having an awareness, I think, is huge.
Awesome. Well, thanks so much, Mary, for coming on. So many insights. I look forward to your future insights because you're really elucidating this super necessary area in the field that we should be paying attention to. And if listeners want to reach out to her, she's at the University of Michigan. She is at the OGS meetings, ACOG meetings, so very friendly. Feel free to approach her because she loves talking about this.
Please do.
She could talk about it all day long.
All the time.
And thanks for coming on.
Thanks for having me. So fun.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
See you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.